it heard from me, Professor Flemming from Novo Nordisk is also a professor from the University of Copenhagen. So today he's going to talk to us about global health in terms of the changing epidemiologic transition. That is quite interesting for me as an epidemiologist. So I'm actually looking forward to this lecture. So Prof, I want to say that with us, we have a group that is following us online. We also have a group that is here. So we have students from various backgrounds. That is, we have nursing, we have community health, we have public health, we have patients education. We have faculty from our two schools, that is the School of Public Health. School of Public Health, maybe they can just, School of Public Health, the representation is there. We also have the School of Medical Sciences. Then we have the team from AMREF Health Africa in Kenya. So I would like to invite our Vice Chancellor to welcome Professor to speak. And then from there, we will be listening. Thank you.
Thank you, Dr. Lakati. Good afternoon. You know, as Dr. Lakati was telling you about University of Copenhagen, I started thinking, does anyone know where Copenhagen is? Where is it? Where? You know, Francis Namisi has been to many places, so he's the wrong person to have answered, but he has answered it. He says somewhere in Denmark, which is in the Scandinavian area of, I think everyone now knows Russia and Ukraine. Eh? It's those sides, somewhere on the northern part. We are very lucky and pleased and privileged to have a professor with us. The reason we do these guest lectures is because we hope that we are training people who can work across borders, that you have global understanding of these issues, that you can think globally and know what's happening in the world, and then you're able to customize these to the needs of our countries. So we think globally and act locally. That is something that we really value. And so when we have opportunity like this, to have one of our colleagues from another country, a collaborator, a partner, we feel very privileged. The other thing is most of you are health workers, and you may have heard Novo Nordisk. Has anyone ever heard of Novo Nordisk? I see the nurses doing that. So there is a pharmaceutical company called Novo Nordisk. So when we started talking with the professor here, I was of the idea of Novo Nordisk, the pharma company, has formed a foundation and they are working on these issues. That's how I was thinking, because that is the common way, you know, of working. But Novo Nordisk is not the pharma. It's like AMREF. It's a foundation. It's a non-profit, which then has enterprises. And one of their enterprise is the pharma that we commonly know, that produces insulin and other things. And I was informed that they actually have 160 other enterprises. So it is not the pharma company owning Novo Nordisk. It is Novo Nordisk, the foundation, owning the pharma company. And when the pharma company makes profits, then it is given to the foundation, plowed back to do charity work, which is basically the way AMREF also works. If our enterprises make any money, it's given back to AMREF to do charity work. And so I was saying that the DNA of Novo Nordisk is very similar to the DNA of AMREF. Maybe if we do DNA studies, there could be some parent-child relationship. I'm not sure who is older. So we are very happy because this is a partner who has our DNA. It's a partner who also is related to a University of Copenhagen, and it's a partner who is ready to share knowledge. And we are thinking of many other ways of collaborating with Novo Nordisk. That's why they are in Kenya. We are hoping that something bigger will come out of this. So it's my great pleasure then to welcome Professor. Please come and address us.
Thank you so much for that kind introduction, and of course the opportunity to speak to you today. I'm here with colleagues. One is in the room, Mette, a colleague of mine. 2 others will join us later. So I've been given the opportunity, and actually it's kind of 2 halves. The one is epidemiological transition and the drivers of the epidemiological transition. And then later, I'll take as an example one of the programs we are hoping to implement also in East Africa. So this is my starting point. Now I don't have a clicker, but I don't know if there's one. There's one here. Oops. Here it is. And I will, of course, make use of the opportunity to compare a little bit Kenya and Denmark using some existing secondary sources. Just back to a little bit about the history of the foundation that Mette and I represent today. So it's actually close to 100 years. Next year, the foundation is 100 years old. And what is important, following up on what was just mentioned, the researchers who discovered insulin were not capable of producing insulin in large quantities, so that was handed over to more of a production knowledgeable group under the conditions that the return on the patents and royalties from the insulin was kept at a foundation level to do good. And initially what we were asked to do 100 years ago was these particular grant-giving objectives. Endocrinology, metabolic disease areas, mainly in the Nordic region, that has now become a global mandate. We were also specifically asked to support clinical hospital services in Denmark, and then also support other scientific, humanitarian, and social processes. This the foundation have done for approximately 100 years in Scandinavia. But with a current strategy that was endorsed a year ago, almost exactly a year ago, we are now turning a lot more global. And since these 160 companies are doing very well financially, look for future partnerships in various areas of work within health. And that's just a little bit of the background to who we are as a foundation. I'll cover these overall aims plus the example of this particular program area I was mentioned to you before. Epidemiological transition. Is that familiar to you? Anyone have heard about this concept before? I'm looking at the students, and I'm sure they have. So epidemiological transition actually was a term that came into being by the now late Omran, epidemiologist, demographer in early 70s, when he was comparing countries around the world and could more or less exactly pinpoint where they had come from, where they would go. He started out with 6 countries and did work modeling on another 18 countries. And of course, that has been more and more refined ever since. And we can now see that pretty much all countries of the world, I shouldn't say pretty much because it is all countries of the world, are going through this changing pattern of disease. If you on your left-hand side are looking at countries that are early in the epidemiological transition, there would be countries with high mortality rate, high fertility rate, high maternal mortality rate, lots of starvation, lots of food security issues, a lot of infectious diseases, very few non-communicable diseases, and so forth. When you turn to the right, it's exactly the opposite. So that transition, all countries are going through. And if we are looking deeper into countries, actually within countries, we see epidemiological transition. Even within a city like Copenhagen or Nairobi, you would find that different settlements, different areas of your city would be at different phases of the epidemiological transition. And then you could say, why is that important? It is important because now we are getting more closer and closer to finding out what is driving this epidemiological transition. I'll get back to that in a second. We can now also see that more and more countries are caught in what we call the double disease burden. I pointed out India here with a gray shaded area. We find that countries undergoing the epidemiological transition, and I dare say Kenya is another such country. Formerly, Kenya entered the double burden of disease 8 years ago and is now caught in the double disease burden epidemiological transition. And that's where non-communicable diseases and communicable diseases are a major public health burden at the same time. And it's not necessarily different population groups. Later, as I'll point out, it can very well be in the same family. It can be in the same person, it can be in the same neighborhood. So it's not just rich people getting NCDs and poor people getting infectious diseases. That's not how it goes. It's NCDs are also associated with poverty. And infection are playing a role in driving the NCD burden. So it's becoming a lot more complex. And this one category of diseases fighting the other category of diseases is not going to work out, because that's not how reality is playing out. We see the different countries, of course, at different stages of this epidemiological transition. Japan is very far, with a life expectancy this year likely to reach 87 life expectancy at birth today in Japan, which is, as a larger nation, the highest. So all of this I'll get back to in a little while. What is driving the epidemiological transition? Slightly different across different nations, but obviously demographic transition is likely to be the most important. Just the sheer fact that median age in Kenya is about 19 years. In Denmark, it's 42 years. So just the fact that there's such a difference in the population average is, of course, meaning that I, as a soon senior person, would have a different disease manifestation, different disease complications. So an older population, of course, have a different pattern of disease than a younger on average population. So that is likely one of the most important drivers. Urbanization consistently comes out as being a driver of epidemiological transition. And with urbanization, we see changing consumption patterns. Here, commercial determinants also play a role, but we see diet, alcohol, tobacco, physical activity, and so on is very different in urban setting as compared to rural. That's also a driver. Africa is the least urbanized continent in the world, but the fastest growing in terms of urbanization. Economic growth play a role, because that play a role on many direct and indirect factors. What if you're looking at the World Bank? They came out with an analysis earlier in January this year. Next to demographic change, next to urbanization, education of girls is what has the greatest influence on fertility rate, on life expectancy, on a whole range of issues. Every single time we start looking at an outcome along the epidemiological transition, we turn back to the factor that educating girls, completing secondary education, getting girls into college education or professional education, and not least getting women into the labor market has a huge impact on fertility and many other factors. We're also seeing major issues with climate change for infectious diseases, but also on nutrition, also on heart disease, also on a whole range of other factors. And what is important to know in the epidemiological transition, you also have possibilities for setback. HIV/AIDS was among the biggest setback we ever saw in the epidemiological transition. COVID-19 have been a setback, honestly, not very much urgently or acute in Africa at large, but in US, 3.3 years of life expectancy have been lost in 3 years. That hasn't happened even during the Second World War. So we do have epidemics, large climate disturbance that can set a country or community back in epidemiological transition. Of course, we also see health sector reforms and development of healthcare technology playing a role. And there, a country like Kenya, but many other countries in East Africa have done a phenomenal job. Actually, the epidemiological transition is a huge success story on how immunization, how improve maternal and child health, how improve child nutrition, you name it, have made wonders to global health. But of course, it does change life expectancy. And therefore, we also see a different, let's say, pattern of disease moving forward. So these particular determinants with various degrees play a role across the world. In the country I come from, Denmark, the introduction of water, sanitation, and safe food is what gave us 11 years increased life expectancy, more than any other intervention. In East Africa, medical technologies have played a greater role, but second to that, only education of girls. So it does vary across the world what is driving the epidemiological transition, but always demographics. What we see very, very fast is a shift, as I mentioned, towards non-communicable diseases. The dark blue is where we see the highest burden of non-communicable diseases, and the communicable, maternal, neonatal, and nutritional diseases are the lighter colors. And the world has gone from 1990, 43% of disease burden covered, measured by disability-adjusted life years, to today, mid-60s in terms of Delhi. So quite a significant shift, and a shift that is just accelerating. That takes me to this. I don't expect you to be able to see it all, but you may follow the Global Burden of Disease Studies that's published in Lancet last time in 2020. You can see the blue are the non-communicable diseases, the red are the infectious diseases, the green are the injuries. And we see that those infectious diseases where we have adequate technology supported by health sector reforms, strong program of delivery, now HIV/AIDS are among those, we see a huge drop in disability-adjusted life years. But actually, we have not managed at a global level to tackle the real difficulty of non-communicable diseases. That's hypertension, that's diabetes, that's heart disease, that's cancer, that's mental health. We're not there. We just don't have to be delivered at scale interventions and the systems in place, or the people trained, or the policies in place. And this will keep developing and becoming more and more blue as epidemiological transition takes place. This will be the name of the game when future nurse midwives, medical doctors, public health professionals are to be trained. We have to move from a thinking of infectious diseases to a non-communicable diseases to the double burden, and not least the multimorbidity. Building a health system, guidelines, educational program that are looking at single diseases doesn't really work. We know that very much in Scandinavia, where multimorbidity are hitting our aging population. It may be infection, influenza, whatever it may be, but it's very much so combinations of non-communicable diseases. The group of elderly in Europe is growing very, very, very fast. And it's history to look at this patient or the citizen to having one of these diseases. You will always meet a multitude of diseases. And our system is so far not capable of dealing with this. Maybe I'll just look at also this from a infection, non-infection perspective. In large parts of the world, you cannot look at a person with diabetes also at the same time thinking of that person as a potential tuberculosis patient. When you're looking at treatment over longer term for HIV/AIDS, you'll also have to integrate diabetes. You will have to look at nutrition, malnutrition at the same time as you're looking at overnutrition. So it's becoming so complex, sorry to give you that, but looking at single diseases, non-integrated disease components and programs and guidelines doesn't really work the way the world is moving. Illustrating this disability-adjusted life years, it is from 19. Kenya is not quite there yet for the Delhis, but moving very quickly to a 50%. And I get back to that data in a minute. So you can see the diversity of non-communicable diseases that are on the landscape. When this was made, first time for 1990, we had 6 NCDs. Now we have 30 NCDs that are actually captured on the Delhi map. It goes very fast. When you're looking at Denmark, disability-adjusted life years, we have fewer of the infectious diseases. This was before COVID, but we have still injuries as a major element, mainly hitting the elderly population, and we have a lot of cardiometabolic disease issues, all along the same comorbidity lines. Death in Kenya also getting closer to 50%. When you're looking at Denmark, it's about 94%, 92% death associated with NCDs. And what I'm trying to point out here is that Kenya is going in the direction of Denmark. What is very important is actually, I think, someone like me, naive as I was, starting out in this field many years ago, I actually thought the research we did in Denmark on cardiometabolic disease would be super relevant and helpful in Kenya. It's not really. 98% of the research done, published on cardiometabolic diseases are done on people that look like me. And the more we get to know about the epigenetics, the molecular necessity of studying molecular epidemiology, more and more we know that what I in Denmark call type 2 diabetes is a very different kind of type 2 diabetes in Kenya, is a very different type in India, is a very different type in the Caribbean. So research on non-communicable diseases and infectious diseases cannot always be translated and transferred from where the research is done in Northern Europe or North America. We need research in communities, else our guidelines are not being updated, and actually some of them would just do harm. So we need to strengthen research institutions in East Africa, in South Asia, in the Caribbean, whatever, to undertake some of the same epidemiological and clinical studies to inform future guidelines, because it's so difficult to translate findings. Last, before I turn to our program idea here, some of you may know the VIS Hub. It's so the Sustainable Development Goals, as you have all heard about, the 17 goals. Initially, I think there was 162 indicators. We now have about 212 or 240 or 14, I can't remember. So all of these are being communicated from each of the 193 countries that are reporting into the SDG Secretariat in New York City at the UN, and they're being monitored once a year. And you can find the data on the VIS Hub. And actually, from a pedagogic perspective, or at your own leisure, it's quite interesting to play around with what are the kinds of investments my country should do to further my country's public health, gaining more and more credits. The 100 is the target, the health targets. On these hubs, we have taken the approximately 40 health-specific indicators under the SDGs, and they're mapped every year. This is the 2022 data that came in. I think at the moment, Singapore is the record holder, Iceland, Norway, and Singapore, the record holders, they have reached about 92 in terms of their overall achievements. So when I look at Denmark, which is reaching 80 on this, I can see there are 6 areas where we just don't do very well, comparatively where we should be. Alcohol, we have a major issue. We have an issue with mental health, for example. And you can look at your own country and say, where do we need to invest? And looking at Kenya, a lot of issues where you're doing phenomenally well. Denmark has been at 80, or 81 actually, for some years. Kenya is actually progressing. So that's the good news. But on NCDs, not so well. Honestly, not so well at all. And that's very important to have NCDs integrated into the general healthcare service and into the infectious disease program. Don't do what Denmark have done, building separate programs to a very large extent, and then having to redo it. It's retraining, it's reinvestment, it's reorganization. Please learn from our mistakes when it comes to the NCDs. But it's actually quite a nice teaching tool, the VIS Hub. And then you can say, if all my investments went into mother and child health, or all my investments went into mental health, where would I stand on the SDGs? Of course, a little superficial, you could say, but from a teaching, quite an interesting perspective. That was the epidemiological transition part, and I better check time. As a university professor, you have the habit of talking a little too much, too long, but I will finish on time. So from a Novo Nordisk Foundation perspective, as I mentioned, we are going more and more global. We are supporting studies on location in populations and genetics and comorbidity issues where it makes sense. And also where we would like to make a difference is on health professionals. And the reason why, for example, Kenya could be a case in mind, we are a little further ahead in India with this program, but we would like to move into East Africa partners also. We are in the fortunate or unfortunate, you could say, situation as a foundation. We don't do any real work. We leave it to someone else. But in terms of building a partnership and getting this going, these are some of the arguments why Kenya came to mind. I don't want to repeat them, and some of these you may want to correct me on, but we see that there's a good reason to invest more in Kenya on this particular area. The cardiometabolic disease area, which is our foundation's main focus, and also in terms of health professionals. And we have this objective for our partnership, and we're especially looking at supporting, I get back to institutions, but supporting the capacity availability of health professionals for those health professionals serving the most vulnerable populations. It would be a little easier to join force with a large private sector actor and get going in urban centers. That's not what we want. We want to focus on vulnerable populations and improving their access to service. And we are looking at both prevention and curative. We are focusing on cardiometabolic diseases because that's kind of in our DNA, but we are well aware that when you are improving an educational institution like a nursing college, it's also more general. We also need to support general institutional capacity. And we have a dedicated focus on, as I mentioned earlier, also looking at women under education and in profession, and the gender sensitive programming approach we would like to follow through on all the activities we do. I can exemplify that a little earlier. We are often met, and I fully respect that point of view, and I actually think AmRef is an eminent example of how it can be done well. But we often meet this argument, which is a fair argument, that you need to build an integrated care model. I fully support. And if we are making an investment, you could also always tell me and my colleagues that you need to look at the entire healthcare system. You need to look at all the building blocks. We accept that argument. What we are trying to do in our programming is identify partners and time periods and geographies where there are others who are investing in some of the other building blocks of the healthcare system, allowing us to focus on the health workforce in this particular program. So sometimes we work with the private sector who are good at production and supply chain and cold chain and delivery, sometimes with NGOs and always with governments who can build other components of the healthcare service. Because then our focus on healthcare providers and health professionals have a much greater impact. If we have the super nurse working in a center that's crumbling and no drugs and no electricity and no water and whatever, of course, that nurse cannot make as much difference. But we are trying to build partnerships where our particular component can add extra value. In at least this particular program, we also have other programs that are a little more integrated, but this is what we are hoping to do, partnering, for example, with AmRef. We have certain principles of engagement which we do not like to differ from. As I mentioned, we don't really do anything on our own. We have to go through partners. The localization, the anchoring is absolutely important. People living in vulnerable positions will be our focus. The gender perspective will have to go through all our programming. So that can be during the education of health professionals. It can be later in life as a professional, and even patient-provider relations, taking the patient-centered approach, gender may play a role. It could be in curriculum, it could be in case material, and so on. We have a focus on developing the CMD, cardiometabolic disease focus, but again, we are sometimes having to branch out like comorbidities, infection, for example. Best practice into research. So whatever we do, we like to have it research-based. And finally, we have a dedicated focus, which I know AmRef have done for many years, researching and developing digital supported learning tools. That's kind of the principles we are working based on. And then we are working on these different pillars. So for many years, a foundation like ours, but generally much more so, general development organizations have liked partnerships and fellowships, fellowships focusing on individuals. We would like to see our investments and partnerships more focusing on building institutions, more comprehensive, more in totality, institutional capacity. Because we would hope to see that after 10 years, an institution is equipped to year in, year out, educate more and better qualified health professionals. Not individuals taken out of context, but the institution is much stronger. That's, of course, our hope and ambition. Then we would like to support the institutional capacity building with implementation and education research, and also always working in networks. So let's say AMREF would network, I know you already are, with a whole range of other institutions. And it could be India, Kenya, Denmark, Kenya, the East African region. We would love to see even more so educational institutions supported by research, stronger in their pedagogic approaches, being networked with other nursing colleges, for example. And we see some of the health professions need a boost to their identity and their skills in the cardiometabolic disease area. And that could be happening in a network approach. Final slide, I think, is this gender part, the analysis to be formed, the gender sensitive approach in implementation, in programming, and also in a lot of what we hope might be at the institutional level, transformative in terms of ways of teaching, ways of management, or the approach to the curricula being taught. So there's many ways, and I'm sure in this room, many who would know more than I do in terms of implementing this in reality, in service, in research, and of course also in the curricula and the teaching of a defined curricula. So this final part was about this PEP program, where we are looking for partners for research, for institutional capacity building, specifically on cardiometabolic diseases, but also, as I mentioned, the epidemiological transition calls for integration. Thank you so much for listening. I do have time, if you have time for questions. I don't know if we have a mic, but else you can speak out loud if there's anyone who has questions or wants to challenge my perceptions here. That's also welcome. No, there's a mic I can see.
So thank you, Prof. Thank you for that. Just one reflection that it is clear NCDs are a big challenge in the continent, but also in Kenya, of course. I just checked quickly, and I think I even saw this earlier. 80% of catastrophic health expenditure is because of NCDs. Today, the percent of total health expenditure in the country that goes to NCDs is only 6.2% or thereabouts. But then we know by 2030, 55% or so of mortality will be due to NCDs. But we don't see commensurate prioritization of NCDs in our ministries. This is just Kenya, but if you go to Tanzania, you go to Zambia, any other country in the continent, you see the same. So what keeps bothering me is, how do we elevate this message, both to policymakers, to make it a priority in politics, but also in policy, so that we see a matching investment towards NCDs, because they are devastating to the economies, and not only to households, not only to our systems. So how do we elevate that messaging so that we see commensurate investment towards NCDs, both at domestic level, but also for development assistance? Because we can look at the total health expenditure, of course, which is important, but also when you look at development assistance, it's the same, more or less. You don't see commensurate investment towards NCDs. You see more investment, of course, even now going to communicable diseases, the big three: malaria, TB, HIV, of course, but very little going to NCDs. And it's great to see Novo Nordisk Foundation choosing to go NCD way, which is not the popular path that we see investments.
No.
So how do we elevate the message? How do we ensure that domestically more investments are going, but also for DA, we are seeing increased investments?
Sure.
I think that's a mismatch that I see.
Yeah.
No, thank you.
Super good point. You may challenge me on this, and I'm not I shouldn't be too overly stating this, but in what I see is, and what I think, is that NCDs is becoming much more privatized around the world. The care, the prevention, the treatment, you name it, the rehabilitation for NCDs is very much like left for the private sector to deal with. And I actually think, and I mentioned that earlier on, I think there's this misconception that infectious diseases, it is for the poor people, but NCDs are for the well-off people. You know, I often hear this idea when Novo Nordisk Foundation are hammering home their message that we are the only sizable foundation that's focusing on cardiometabolic diseases. And I don't want to name names, but you could imagine a handful of large foundations. They look at us with a great skepticism, because if you get type 2 diabetes, it's your own damn fault. You call it lifestyle diseases. You have chosen your own lifestyle. You're obese. You don't move around enough. You eat too wealthy food. That is so wrong. That is so wrong. I mean, going to major urban settlements, poor settlements in Nairobi, you find type 2 diabetes. In the poorest segments of the population, I know you also find it in middle class, but you find tuberculosis and diabetes, they're sleeping together. And you find malnutrition and hypertension in the same person. So I get so upset when I hear my national donor agency, Danita, or colleagues in the big foundations. They don't want to talk about NCDs because they think it's your own individual created problem. What nonsense. So the government feels that that can be left with the private sector. Buy your own health insurance. Go and get your own drugs. That's part of the story. The other part is the sad reality that Mexico is now facing, Colombia is facing. If you accept too late that NCD is a problem and you include it into your health coverage, your central bank is going bankrupt. So part of it is we don't want to accept it, even though we can convince them with data, because what are we going to do financially? It's not like when I worked in Kenya a long time ago, 3 Fansidar tablets, over and out, off you went. This is for life. So it's a huge cost. So we have to prevent, and do secondary prevention. I mean, there's no way out. And every single time one of the nurse graduates from Amref gets an opportunity to talk to a patient who has, been through a preeclampsia situation, gestational diabetes, or anyone who has tuberculosis or whatever, you have to talk about NCDs. That opportunity will have to be there in every single consultation. But we need to change the mindset of the public and the politicians. NCDs are also for the poor, and development assistance have to support healthcare systems in integrating NCDs. Else we are off to a very bad start for the next generation. Sorry. Anyway, I liked your question, as you can hear.
Thank you very much. I think I want to, you have partially answered my question, or even reflected on the comment I wanted to make. As you are discussing, couldn't help it, but I could see you, your presentation taking us to look at the broad determinants of health rather than focusing on the causative agencies that we have been for a long time. And I know that moving that path is like going upstream. swimming upstream is not, it's not very easy. You need to use quite a lot. So I know with the Denmark, first of all, thank you very much for being part of the early KP immunization program, which actually helped us deal with the childhood diseases. And I think a small country with a big heart. And I know that even getting into this, we could have a start to change the mindsets. And changing the mindsets means doing something before to demonstrate that it is possible for us to do that. When you talk about the underserved and the rural, I always look at some people are on the periphery, but others are on the periphery of the peripheral. When you look at Nairobi as a city, there are people who are living in conditions that are worse off than those that are living in the rural. So as we map out how we can deal with non-communicable diseases, I like the path you have chosen, focusing on the capacity, building the capacity of the front health workers. And I hope as we think through this, we'll look at that community health worker who is in a village, who is able to who knows and experiences what patients that are suffering from non-communicable diseases go through, will be the first level of contact. And designing programs that can cater for that so that prevention becomes the primary focus, that will be very helpful. And research is needed even at the lower level. And research that is done, as you rightly put it, that is done by, sorry to use the word, experts, yeah, it remains an expert research. How about that level at the community level? How about that research being done and being the evidence being used to transform the way we think? I think that would be a path to go. The last one is, I know you are in Denmark, there is quite a lot of experience. But as you said, this is a different context. Yeah, but it's not entirely true that there's nothing that can be learned from what has happened in Denmark. I know you've been Nairobi, you're in Nairobi, you've been Nairobi again in Kenya. And when you look at this road, when you start talking, or most of the roads, you start talking of people exercising, or, I mean, it's just like, there's no infrastructure. Yeah, the infrastructure here is built for the traffic, mainly the mechanized traffic. And those are some of the things, when you talked about working with others, I was excited. It's not a question, but it's a comment. Thank you very much.
Sure. Thank you. I don't want to, I mean, I agree on all your reflections, just also on the abstractness of some of these determinants, urbanization, and, you know, what to do about it. I fully agree, urban planning and all of that have to be integrated, but at a more, let's say, health systems, health professional link, when I was looking at the data on hypertension, undiagnosed hypertension in Kenya, it's pretty scary. It's pretty scary. There's no reason why you have so high levels of undiagnosed hypertension. That can be done at community level. We also have pretty simple, very cheap drugs. So of course, I don't want to leave it all to the abstract. Today, we have effective interventions for a whole range of these entities that are taking them for being a trivial, let's say, point of treatment and intervention, preventing them from becoming this, as someone mentioned, you know, killing your financial resources. I mean, we have for entities, and that knowledge, some of that has been generated from all over the world and can, of course, be applied in Kenya or any other place in East Africa for that matter. So yes, we do, of course, have knowledge we can transfer, but we need a lot more knowledge generated from a biology and from a context that resembles situations of Kenya. There's no way around it. We can't fool each other that great science done in Copenhagen or Boston or Tokyo would all be applicable here. It's not. Anyway, and I agree with your other comments. Yes. Yes.
Yes, hi, hello everyone. Thank you for giving me the floor. Thank you for the presentation, Prof. I have a question. That is more of it is a question, but an observation also, because 15 years ago I worked on obesity in Mexico.
Prof, we have some people online
Yeah.
who are ready to ask questions. I hope we can hear them.
I think Axel has a question.
Yes.
Is that her name? Or
Yes,
his name?
Axel is my name, Axel Ibodi. Sorry, I did not introduce myself.
Mamtaz, are you able to unmute yourself and speak?
Yes, Doc. Yes, Doc. Hello, I am Mumtaz Mohammed, MPH student. I would like to ask one question about the engagement principle.
Or maybe as a
of the-
chat.
Can you hear me? Can you hear me?
Yes.
Okay, so I would like to ask a question about your engagement principle on people living with vulnerable positions. Considering that we are in a country like Kenya, where everything nowadays is being commercialized, including the mental health programs that are being run, and to the extent that the rural people, or from the grassroots, many people do not have the chance of getting these services. As you, as a prof, conducting this program and looking for partners and all that, how are you planning to cap the aspect of commercializing everything that pertains the health sector in when it comes to NCDs or any other programs, especially the mental health? Thank you.
That's a very good question. So I see your point, and it's true that a lot of mental health services are becoming privatized or online privatized. So the only way we as a foundation can deal with this is, of course, working closer with civil society actors that might have a different approach to profitability, to government services with a different approach to profitability. In India, for example, we work a lot with faith-based organizations who have a different approach to profitability. And some of these programs also have to be taken to scale by private actors. So it is I mean, we cannot rule out that there will be private for-profit actors involved in a whole range of these services. But I agree with you that we can make differential services. We have some success in doing that. But as a foundation, we can primarily work through or only through partnerships. And the combination of partnerships more or less adequately can deal with this marginalization. But yes, I agree with you. It's difficult to reach, the hard to reach, getting to the vulnerable, that would have to be a targeted partnership approach to make it happen. I don't know if that was of any use, but.
Thank you so much.
I think we have.
Axela, maybe you can take your question. Axela?
Yes, I'm here. Thank you for giving me the floor. I was asking if one way of changing the public approach could not come from the way how development is seen in our countries, because I worked 15 years ago on obesity in Mexico. And one of my findings was that people were accessing the development through their way of eating. That led to the high obesity rate, and that goes hand to hand with diabetes and all what they are facing today. So I wonder if in a setting like Kenya, the approach to the gastronomy, to development, could not be changed, because I'm not a Kenyan, but I've been working on Kenya, and I was really shocked to find out that you will find all the international, multinational of fast food there. So it was a shock for me, because I'm from the another side of the continent. So is there a margin of work people can make at the community level regarding the gastronomic culture in order to tackle, to mitigate the effect of NCDs?
Yes, that's also another super relevant question and super difficult. I think if we boil NCDs and these drivers are transitioned down to commercial determinants, I think we would find a lot of commercial determinants driving this, especially but both cancer and cardiometabolic diseases. I think there's been a very good step made within the Tobacco Framework Convention. The Tobacco Framework Convention is showing the way for some of the dealings with the commercial determinants. It has been 25, 30 years of struggle, but it's making a huge impact in terms of sales restrictions, pricing, in terms of commercialization, you name it. And making something similar, you made reference to Mexico. They were trying to introduce a sugar tax and have now a sugar tax because it's the population of the world that consumes most per capita fizzy drinks. So I think you're absolutely right that a lot of the salt content, a lot of the tobacco, the alcohol, the fat, trans fatty acids, and so on, it deals back with policies and commercial determinants. And we do have examples from around the world that if politicians listen to science advice and have civil society partners, I mean, we can make a change. We do actually have quite a few examples, but it's super difficult on sugar and it's super difficult on meat products. But we have examples from salt and from tobacco and some countries alcohol. And yes, I agree, if we want prevention, we have to deal with the commercial determinants. There's no way around it.
Thank you, Prof. There's another hand up from Grace. Grace, you can ask your question.
Thank you, Dr. Thank you, Prof, for the presentation. From my field, I work in gender-based violence field, and we have seen a lot of research that have been done where there is a relationship between gender-based violence and infectious diseases. So I would like to know from you whether you have done any study or you are aware of any studies that have been done that can connect or link gender-based violence with non-communicable diseases. Maybe if you have anything you can mention on that. Thank you.
Yeah, I don't think it's a well-studied area. There's interesting studies from India. Actually, prevention of NCDs take time. And one of the resources that women in this part, it was studies done in Chennai in India. One of the resources that were being pushed or pressured was time for women to actually be involved in a whole range of health promotional activities, leaving resources aside for the women to be involved and time for them to be involved. That came out as a very gender associated, let's say, risk. I don't know if any of those particular circumstances were linked with domestic violence or intimate partner violence, but gender is very much part of access to healthcare, access to the increasing privatized healthcare, we see in a whole range of countries where heart disease is an issue, of course, across gender, that men there are greater investment in maintaining men involved in heart programs, as they're called in some countries, as compared with women. So I'm sure access, changing diets, time allocated for physical activity also has a gendered component. But again, to the best of my knowledge, it's not a very well-researched area. For chronic care, we see that drug components play a major role. It's very costly. It's very costly. And there, the entire family will have to allocate sufficient money for drugs and for secondary prevention treatment at general. And that always becomes the fight over resources within a household. In many contexts, would have a gendered component.
Thank you, Prof. I don't know whether we have.
Thank you, Professor Flemming, for that wonderful, thought-provoking presentation. My name is Patrick Kokwara. So I wanted to, in thinking about the epidemiologic transition, we have a new concept called the syndemic of diseases, which I'm sure you are familiar with. So in this side of the Sub-Sahara, we have aspects, for example, of diseases, the NCDs and infectious diseases interacting side by side in the context of structural problems, which are making them worse. So in your intervention, again, thank you for the good work you're doing, as Nora noticed in your intervention. So you come in, apart from addressing the NCDs, the cardiometabolic diseases, do you bring in, or rather look at the structural aspects that are making these diseases, these endemics that are existing side by side, worse, so that you are sure that you're having far-reaching interventions that are able to change the way things are happening. Thank you.
Thank you so much. I guess, no, please go ahead. I don't want to cut it short. I don't want to people either. Okay.
Thank you, Prof, for that good presentation. My name is Dan Kanirongo. I looked at the data that you provided on the disease burden. 2019, 64%. That was 1960 something, under 40%. Completely walling, but maybe not surprising. I also liked the comparison that which you are drawing about a research and the way it would apply differently from one continent to the other. So I'm looking at our context, the Kenyan context, and when I look at this data, my thoughts go to health financing. So when I look at NCDs like cancer, diabetes, we are in a country where we are seeing a lot of these happening a lot, but because we are also supporting education for health professionals, we are also in a place where we have got doctors and nurses that get trained, but they are not getting absorbed. So I don't know what your thoughts would be around that. Healthcare financing. And is there a classical example of countries or places where you think they are doing it and they have done it well? We have devolved health. And therefore, there are issues that which one would think and imagine images are out there. The other thing that which I would love your comment about, I like the model of your foundation. That really struck me. So you have got 160 enterprises which are commercial and they are supporting foundation. What would your comment be about organizations like AMLEF or even universities for sustainability? Where do you see, what would you advise, what would your comment be about looking at a model that which has got enterprises which are commercial and then supporting the core business? Thank you.
That was a lot of issues.
Sorry.
Yeah.
I'm trying, I don't know whether you are able to remember the questions so that I allow one more person
Sure.
online.
I'll do my best.
So that you can take the questions and we come to the end. Yared, are you able to speak?
Thank you so much. Yeah, my appreciation goes to the organizer and speaker, the professor. I'm Yared from Ethiopia. I'm Rafael's Africa. It's not a question, but just sharing with you a context, how CMD is hidden in this mixed and transition period. The case is the result of a supportive supervision from a mobile health service for a community, which is located in Somali regional state. And the community is getting periodic mobile health service. It's a riverine community, far away from health center and health post. And the community was in dire need. Their basic dire need is like water, road, clinic establishment. However, during the supportive supervision, what I have found with my team, they had in the preceding six months, 3 maternal deaths and quite a number of newborn deaths. In the midst of this, while we were screening, both physical and other examination, we had quite number in that 100 household community, facial palsy with raised blood pressure, mothers with hypertension and diabetes and other cataract. I mean, just this is just not a question. Just to show you how mixed in a community where they are still requiring the basic one, but they have the complication and mix of this epidemiologic transition of having chronic metabolic diseases. I'm just sharing with you a story and context. Thank you so much for giving me the opportunity.
Thank you so much. I'll get to the two broader comments and I what you just explained from Ethiopia is reality and obviously scary. Because what kind of a health professional and health system and resources that would have to be available to deal with this diversity and real life double burden. I mean, I fully respect that this is a very daunting task. And many years ago, I was living in Addis, and even then there was discussions on cancer, cervical cancer. And back to an earlier point made in the audience, at that time, we knew that women coming with stage 4 cervical cancer who had not been diagnosed sufficiently early, I mean, they had no chance. And the international donor community and the government would not want to accept HPV vaccines. On the healthcare financing, we now have super efficient HPV vaccines for boys and girls. Of course, you may want to start with girls, but boys and girls, it makes no sense from a healthcare financing perspective. It didn't then, it does not today, that international and national donor community does not support a full-scale rollout of HPV vaccines, for example. And the same goes for a whole range of other preventable or early treatable entities, but they have not been part of the curricula, that not been on the political agenda, and they're nowhere to be found in donor community discussions. I mean, that's your reality from Ethiopia. That's a reflection of it has not been taken serious for many years. And I think we also owe ourselves for future generations. I've been working, at University of Copenhagen. We started our Masters of International Health. I'm a mosquito man myself, for many years. We did not have NCDs sufficiently embedded into our program. We did not. I mean, so I'm to be blamed like many others. So let's also look at our curriculum. We don't have enough integration of NCDs. And that's no good, because if we don't take it serious, no one else will take it serious. And that's also, I think, what we are facing in Ethiopia, as the example was. And that brings me to healthcare financing. It is a real issue. I think some of the examples you probably all know about the healthcare insurance scheme in Ghana, starting 15 years ago, which is now the model for health insurance, government-based health insurance, co-investment by enterprises and public. I mean, that's part of the story to support the healthcare financing. But it's also to look at the rules and regulations to attract more competition into the pharmaceutical sectors. It is also making it more attractive for the private sector to provide new at-cost drugs. I'm surprised to see how many private pharmaceutical companies that want to supply drugs at production cost into a country like Kenya, but it needs an investment in supply chain, storage, and healthcare personnel. I think there's an opportunity for Kenya and many other countries to accept the enormous political pressure. Fortunately, there are on pharmaceutical companies to deliver at cost into the government healthcare services, but it requires political commitment and investment in infrastructure for delivery. So I think there's a lot we can do also from a financial perspective. And that goes early on, because in the epidemiological transition, overall, there's also one for NCDs. And when we are looking at the transition, NCD transition, it starts with hypertension. Then it goes to type 2 diabetes. Then it goes into broader cardiovascular disease. Then it goes into cancer and so on. So let's start with these early risk factors of NCDs, because they can be done at low cost. And it's an enormous rate of return. WHO have just published their heart data for hypertension. Except for water and sanitation, you don't find a rate of return as high. For every dollar invested in wash is $25 back. On family planning, it's about $20 back. On heart anti-hypertensive drugs, it's about $18 back on invested. So there's no reason why we don't do it. But if we don't train our healthcare personnel to push it and deliver that drug, the companies that want to deliver it into the country won't have a chance. Anyway, on that note.
Thank you very much, Professor, for taking us through the lecture. Just my comment is, as you exit, maybe my comment is actually I like the mindset that your foundation has taken in terms of going forward and saying we cannot separate NCDs and call it a disease of the rich. And I think that takes us back to where we were many years ago with HIV, where in our settings, if you had HIV, then you are stigmatized. It's your problem. You are the one who did not do the right things. And that is, I think that is a stigma now that NCDs are facing that require really a multi-level and multi-sectoral, because if you look at, we need physical planning in our cities. We need physical education. We see today that we are putting physical activity at the back. It's more prestigious to use a lift than walk. And even we see, even in our school setup, physical activity is used for punishment. So there is a lot of work that we have to do in this area. So we need multi-level, multi-sectoral, but also importantly, something my colleague said there, we need to also fund research that uses innovative ways of dissemination, so that the dissemination is not only to the scientists, but to that community person who is actually affected by NCDs, because that is the only way we can pass this message to the people who are affected. Thank you.
Yeah, and maybe ending off by Halfdan Mahler, the former, now late Halfdan Mahler, who was director of WHO years back, father of the Alma-Ata Convention, Public Health. He said public health is about the allocation of scarce resources to areas with the greatest impact. And I think that's now where the NCDs are probably getting into the picture. So leaving on that note, thank you so much for listening, and online, thank you for your contributions.
Thank you very much, Prof, for really that useful talk that we have had this afternoon. And we have had more people actually online. And I hope you are able to appreciate that as a university, we have been able to reach to train our students virtually, and that's why we did not have a group here. We have actually 100 postgraduate students at the moment who are studying from several countries, and they've been able to follow online as well as our colleagues from countries. There are also comments that have been shared on chat appreciating the talk, and this is really has been an exciting day. I want to welcome our Vice Chancellor to say a few words. Then from there, we shall be closing.
Thank you, Alice, and thank you, Prof, for a very engaging session. As I sat there, I was just thinking how important it is to integrate NCD services into everything we do. As some of you may know, I have reduced my medical practice to seeing patients with sexual problems. When I started doing this, every time I came across a diabetic, I referred them. A hypertensive, I referred them. Until I realized that it was becoming too much. And they were not even going to the physicians I referred them to. And now I have ended up treating more diabetes and hypertension than sexual problems. The reason being that a good chunk of sexual problems are really a symptom of NCDs. So when you work up these patients, then you realize really the problem is not ED, it is uncontrolled diabetes, which may not have been diagnosed at any point. And so I've ended up doing a lot more NCD treatment. But that is just to say the importance of integrating NCDs into everything we do. If you're giving family planning, you will be taking blood pressure, and you will realize that many of these clients have never had their blood pressure checked. And you end up treating the blood pressure and even giving a different contraceptive from maybe what you'd have wanted to give. So let's integrate. But I want also to say how interlinked Novo Nordisk Foundation and how the thinking process is so similar to what we are doing in the university. As you're talking about gender issues and issues related to diversity, I just realized this is exactly what we talk about here. We even have a committee that deals with diversity, equity, and inclusion. And we are looking at gender issues, we are looking at displacement, we are looking at people in far-off places, people with disabilities, and how they can be part of the university community. And so that for us is very important. Now, interestingly, the majority of our students and staff are actually female. We feel happy about that, but we also hope we will have more men in the, in the future. It may not mean that we are reaching the disadvantaged girl children. We don't believe so. It may just mean that parents who want their children in universities find it safer in AMREF University. And so we end up with more women. We are happy about that, though. Fortunately, we also have more female staff, and we are happy with that. And we are, in our strategy, really talking about how we escalate training, how we use innovative methods of training to reach people at a distance. And so when you talk about novel training approaches, we are exploring them, and especially looking at student-centered, student-led kind of training, and trying to test some of the models and seeing what works best. I think for those who have been here long enough, you may know that our integrated virtual face-to-face training for nurses, which started in AMREF quite a long time ago, has been shown to lead to higher pass rates in the nursing council exams. And so we have some evidence that traditional training may not always be what works. There are other better ways, and we are exploring much more. We are happy to work in this area with you if resources allow. The gap between education and practice, again, something that we really are thinking about. If you sit in interview panels, one of the depressing things that you come across is that the papers and the skills don't match. Papers from universities, PhDs and masters and bachelors, and you ask people practical life questions, and the papers don't speak to the skills and abilities. In our university, we aim to bridge that gap. And that is why we very much value linking class work to projects, and being part of AMREF Health Africa, having trainers who are also practitioners, having exchange programs, and having students out in the field. Those are things we value very much. And again, therefore, that speaks to how connected the thinking in the foundation is to the thinking we have in the university. I'm really hopeful that as we go forward, given these many areas of convergence, we will have a lot more areas to talk about and to work on. As I end, we have George Kimathi. For those coming from AMREF Kenya, because you may not know, in the university, George has a different role. He's my boss. He's a member of the council. And so he will come and say a word and close for us today. George, we appreciate you and welcome.
Good afternoon. I never knew that I'm the VC's boss. But Prof, thank you very much. And I don't want to repeat what Prof you said, but it's been a great afternoon together. Thank you, Prof Flemming, for the lecture. AMREF has been the space of building capacity, building systems for human resources for many, many years. In fact, for most of the partners that you meet, they will know AMREF because of the connection with the communities, as most of the colleagues have said, but also because of our training programs that I've run for many years. And I think one of the most important things that you list in your very stimulating lecture is the need for us to build the capacity of the health workforce, so that as we discuss NCDs, as we reflect on some of the questions that were coming regarding financing for NCDs, building the political momentum for increased investment for NCDs, We also ensure that the health workforce that we have in our facilities who are interfacing with the patients have the right skills to provide services, all the way from promotion to prevention to care and palliative support that's required. I think that's very important. What makes us so happy this evening is that Novo Nordisk Foundation has decided to invest in that space that is so huge in terms of a gap. And we are so happy to walk this journey with you. And we look forward to further conversations. AMREF got involved last year with the Ministry of Health, most of us will know, to assist the ministry to think through the best way to review curricula, to ask ourselves, if what you showed us here is the situation in our communities that we also know, and this is the forecast in terms of where we are going to be in 2030, 55% mortality in our communities, then what kind of healthcare worker do we require today to prepare for that future? And so we work the journey with the ministry to help them to think through and asking ourselves, is this a time actually that we should put aside the curricula and the content that we are using to train and come up with the curricula that speak to the needs of our population today and in future? That is so important. So the conversations that we've been having with your team, Prof, and that we had this morning, asking ourselves how best to ensure that any CD content is reflected in the curriculum and the content that is today to train our workforce is so timely. And we want to thank you because of that and look forward to working with you. I want to appreciate Professor Joachim, thank you so much. Dr. Alice, thank you for organizing this for us. And of course, the university fraternity for the questions. I realized at one point, Alice said to minimize the number of questions and colleagues who wanted to comment. But you know, that tells me something. If you do a public lecture and there are no questions coming to you, Prof, you know what that means. It either means people have really understood or actually you've said nothing. But if you stimulate people, and if the topic that you are sharing is so close to their hearts, then you go through what we've gone through today. So many people from across countries wanting to engage, so many people from the, in the room wanting to engage, wanting to ask questions, but also to comment, because it's very close to our hearts. But it's also because it's a huge challenge to our country. That's so important. So thank you so much for that. And thank you, colleagues, for the engagement with the Prof. Thank you for the great work that you're doing for the university. Now, as council, I see the VC looking at me. As council, count on our support for continued, for the great work that we continue to do for this university. And with those few remarks, I want to declare the session officially closed. Thank you.